Hi everyone, thank you for joining this renal tutorial on acute kidney injury. It's given by Mara. So just a few rules. If those of you that are watching via Zoom, if you've got any questions or comments that are covered in the moment, if you just want to pop it into the chat, any question that can wait into the end, if you just want to pop it into the Q&A. If you're watching on the Facebook Live, just comment your questions and comments and we'll pass them on to the tutor. That's all from me now. I'll hand over to Mara. Thank you.
Hello, everyone. So I'm Mara, a third-year medical student at King's College London. And today I was thinking about, I thought we would talk about acute kidney injury, which I know can be quite a daunting topic in terms of classification and as well as management. So I'm hoping to keep it as clear as possible and sort of systematic. So just a quick disclaimer. Obviously, this shouldn't replace your formal teaching, and you shouldn't take it as official medical advice or anything like that. So yeah, in terms of learning outcomes, they are quite broad, but understanding the AKI staging system, how we can classify acute kidney injury, common investigations and why they're performed, and also thinking about the principles of management. So first things first, defining AKI. So that simply means acute kidney injury simply means an abrupt reduction in kidney function, which usually leads to changes in your laboratory values. And what do I mean by that? KDIGO, so Kidney Disease Improving Global Outcomes, defines AKI as either one of these three. So a rise of creatinine of more than 26 micromoles per liter in 44 hours, a rise of 1.5 times from the baseline within 7 days, or a urine output of less than 0.5 milliliters per kilogram per hour for more than 6 consecutive hours. And by the way, I want to mention that if at any point you have any questions, do type them in the chat box and I'll try dealing with them throughout the lesson if they're related to what I'm saying at the moment. All right. There are some risk factors which increase your likelihood of having AKI, and the most important ones are being older, so 75 years of age or more, having chronic kidney disease already, so you can get acute kidney disease on top of that, having heart failure, hypovolemia for various reasons, which we'll see in a bit, or if you're undergoing a renal transplant, or any investigations which require the administration of contrast dye. Now, kidney disease can be classified into three main, acute kidney injury can be classified into three main stages, and these are based either on your serum creatinine or your urine output. And you can have a look at this table. So if there's an increase of more than 1.5 to 1.9 from the baseline, this is stage 1. Stage 2 from 2 to 3, and so on. Or these decreases in urine output, which you can have a look over in your free time. But I want to clarify what baseline means. So baseline serum creatinine is the lowest value that you have recorded in the last 90 days. And obviously, it's possible that you might not have that available, in which case, if you don't have any reference value available, but you are worried about AKI, you would want to repeat the serum creatinine within 24 hours from the patient presenting with a suspected AKI. Now, in terms of causes, they can be split into three main types. Do you guys have any idea what's the main classification of AKI causes? You can type them in the chat box if you want. All right. Well, it can be, yeah, perfect. So pre-renal, renal, and post-renal. Well done. So those are exactly the ones. So pre-renal simply means related to anything that comes before the kidney, so mainly your blood supply to your kidney. Intra-renal happens within the kidney, and post-renal, obviously, as the name suggests, anything to do after the kidney, so your ureter, bladder, urethra, all that. So pre-renal is usually due to impaired perfusion to the kidney. Renal is either damaged tubules, glomerulus, interstitium, or vascular damage that's supplying the kidney, or post-renal, which is usually due to obstruction of urine flow from the kidneys. And I think this is interesting to keep in mind. So most AKI is caused by either pre-renal failure or acute tubular necrosis, which we'll see in a bit. This is a intra-renal cause. So these add up to 80% of the patients you will see with AKI. Now, we should go into a bit more details in terms of classifying the pre-renal, intra-renal, and post-renal causes. So can you guys give me example of pre-renal causes of AKI? Okay, yeah, I see hypertension. It's more likely that you would get AKI from hypotension actually, and this is a cause of pre-renal AKI. So you can be in a hypovolemic state, either which would also be associated with hypotension. You can be in a hypervolemic state. So okay, it was a typo, yeah. So it's hypotension. You can be in a hypervolemic state, or it can be caused by various medications. Any ideas about intrarenal causes? Acute tubular necrosis, yeah, perfect. That's one good example. So this is just going into a bit more detail. Nephritis, yeah, for intrarenal. Good. So intrarenal can be basically split into the component parts of your kidney, of your nephron. So your glomerulus, tubule, interstitium, or your vascular supply. So if the glomerulus is affected, you would get a glomerulonephritis. If the tubule is affected, you get acute tubular necrosis. From interstitium can be affected by either drugs or infection, and you can also have vascular intrarenal causes. And we'll go into a little bit more detail about everything in a little bit. What about post-renal causes? Can you give me any examples? Yes, ureteric stones, perfect. Any other ideas? Enlarged prostate, yeah, that's a very important one, especially in elderly males. Strictures, yeah, perfect. So I've sort of split the post-renal causes into causes related to the ureter, the bladder, or the urethra, or simply related to drugs. So ureter, as you said, kidney stones, retroperitoneal fibrosis, abdominal tumors. Bladder, once again, stones, you can get those there as well. Benign prostatic hyperplasia, which is the enlarged prostate you've mentioned, cancer, for urethra, stones as well, phimosis, and different medications. Now that we've basically figured out a general outline of how AKI can be classified, I think it's worth going into a little bit more detail about the pre-renal causes. So in terms of hypovolemic causes, we've already mentioned hemorrhage, GI losses. So these can be either vomiting or diarrhea, renal losses. So if people use diuretics and they overuse them, or because of osmotic diuresis, which can happen in diabetic ketoacidosis, dermal losses, which are basically burns, or another cause, which isn't quite hypovolemic, but I've sort of put it under this umbrella, which is hypotension caused by either sepsis or neurogenic shock. So these first four causes are hypovolemic ones because there's loss of fluid, which will lead to a decreased perfusion of your kidney. Whereas this third one, you aren't necessarily in a hypovolemic state, but because sepsis can lead to vasodilation, same for neurogenic shock when there's loss of sympathetic tone, there will be a decrease in the perfusion of the kidney. And for this, in terms of signs and symptoms associated with hypovolemia, would be you'd get tachycardia, so increased heart rate, low blood pressure, reduced skin turgor, and cool extremities. So these are just general signs and symptoms associated with hypovolemia. Well, okay, yeah. And the great news is usually when you have AKI caused by hypovolemia, the kidney function will improve considerably once normal perfusion has been restored, especially if you do that in a timely manner. In terms of hypervolemic shock, this is usually due to two main causes, so either heart failure or liver failure. And I've written here that heart failure can lead to cardiorenal symptom, which manifests as hypotension, fatigue, dyspnea, and edema. And the reason why this happens is your heart is failing, your cardiac output is decreased. Because the cardiac output is decreased, that means that the kidney perfusion will be decreased as well, which in turn leads to the activation of the renin-angiotensin system, which will mean that you will be retaining more water. So even though the heart is failing, you will be fluid overloaded. You'd get edema because of the RAS system. Whereas in liver failure, this leads to hepatorenal syndrome, where the main signs and symptoms are hypotension, splenomegaly, caput medusae, ascites, and peripheral edema. And the reason why this happens is because you have liver failure, this leads to splentic vasodilation, which means vasodilation of the vessels which are supplying your intestines. So if those are vasodilated, this will mean that less blood will actually be reach the kidney, which will once again lead to the activation of the RAS system. So you get sodium retention and fluid retention. And at the same time, because the liver is failing, you'll have low levels of albumin, which will mean that it will be quite hard to keep the water inside the vessels, inside the blood vessels, so it might leak into tissues. This is why you might get ascites, for example, and peripheral edema. So these are sort of the hypervolemic states that cause AKI. Now, in terms of medications, does anybody know any medications that can cause AKI? Yes, NSAIDs, perfect. Yep, all right. So exactly, NSAID is a very important category. So NSAIDs and ACE inhibitors, as well as angiotensin receptor blockers, cyclosporines, and tacrolimus, which are immunosuppressive medications. And I think it's useful to know the mechanism for how NSAIDs can cause pre-renal AKI. So what happens with them is NSAIDs decrease the production of prostaglandins, and these prostaglandins normally cause vasoconstriction. So with the decreased production in prostaglandin, you will get vasodilation and decrease in vasodilation, which will lead to afferent arterial vasoconstriction. So the afferent arterial is the one that brings blood to your glomerulus. So if you have afferent arterial constriction, this means that you will get a decrease in the pressure gradient between the afferent and the efferent arterial. So your glomerular filtration rate will decrease because of the afferent arterial constricting. Whereas in ACE inhibitors, what they do is they inhibit efferent arterial vasoconstriction, which means that it will be larger, it will be dilated, which once again will lead to a fall in filtration pressure because this pressure difference between the afferent and the efferent arterial will decrease. So once again, your GFR will be decreased as well. In terms of how cyclosporines and tacrolimus cause acute kidney injury, the mechanism is relatively similar to NSAIDs, but there are multiple things that contribute to pre-renal AKI with these medications, so I won't go into too much detail about them. All right. Now we've covered the pre-renal, so we should look into renal causes. So first things first, how is the glomerulus affected? So this is usually due to glomerulonephritis, which simply means any condition that causes glomerular inflammation. And these can usually be split into nephrotic or nephritic conditions. And I've put here the main differences between nephrotic syndrome and nephritic syndrome, but we won't go into too much detail about them. But nephrotic is basically characterized by proteinuria of more than 3.5 grams in 24 hours, hypoalbuminemia, and edema. And these are some examples. Whereas nephritic syndrome is characterized by proteinuria of less than 3.5 grams. So this is an important distinction. And you might also get hematuria. And IgA nephropathy and anti-GBM disease are some examples, but you don't need to worry about them for today. In terms of how the tubule can be affected, we've already mentioned you can get acute tubular necrosis, which is a very common renal cause of AKI. So 85% of renal causes are due to acute tubular necrosis. And this can be due to two main reasons. So it can be either ischemic or from nephrotoxins. What do I mean by ischemic? Well, when you have a decrease in kidney perfusion for a long time, potentially due to a pre-renal cause, you will get in the end intrinsic renal damage. So if you have pre-renal AKI that you aren't treating, your kidney isn't being properly perfused. So in the end, kidney cells will start dying and you will get acute tubular necrosis. Does anybody know any nephrotoxic drugs that can cause acute tubular necrosis? Penicillins, yeah, that's a good, interesting thing that you've mentioned. They are more common in causing acute interstitial nephritis rather than acute tubular necrosis. But yeah, aminoglycosides, I see somebody mentioned gentamicin, which is an antibiotic, methotrexate, heavy metals, radiocontrast dye, and ethylene glycol, and you would get a patient that might as well be confused and they might present with dilated pupils as well. So this is good to keep in mind for differential diagnosis. Or it can be caused by rhabdomyolysis. So this is muscle breakdown from the myoglobin that can deposit around the tubule. Hemoglobinuria from hemolysis or from uric acid levels. And basically these are either exogenous causes, the first things you've seen, and these are endogenous causes, so due to things that are produced within your body. And the great news is, tubular cells have a very high rate of repairing themselves. Like new tubular cells are always being produced, so that means that you'll get spontaneous recovery in 1 to 3 weeks in many cases. In terms of interstitium, we've mentioned acute interstitial nephritis, which simply means an immune-mediated interstitial inflammation. So this is it can be either type 1 or type 4 hypersensitivity. So it's sort of an allergic reaction, we can think of it that way. And it's mostly caused by various drugs. So it can be due to NSAIDs, penicillins, and allopurinol, which is given in gout, or diuretics, such as thiazide diuretics. And with this one, since it's an hypersensitivity reaction, you might get a fever, rash, joint pain, or eosinophilia. So I've made a slide which compares acute tubular necrosis with acute interstitial nephritis, simply because I think it can be quite difficult to tell them apart. So once again, acute tubular necrosis is due to ischemia or nephrotoxic drugs. And you might get in the urine muddy brown casts, which are just sort of transformed epithelial cells from the tubular necrosis. And once again, from medications, contrasts, things like that. Whereas acute interstitial nephritis is a hypersensitivity reaction. So it's not due to direct nephrotoxicity. So it's an inflammatory process, which might lead to white blood cells in the urine. raised IgE or eosinophils, and you will also get symptoms such as fever, rash, arthralgia, and it's usually due to NSAIDs, antibiotics, diuretics, the thiazide ones I mentioned. I see somebody is asking about gout, so allopurinol can be used to treat gout. All right. In terms of vascular causes, so this is basically due to the vascular supply to the kidney, which can be compromised in some situations. So it's not related to the glomerular vascular supply as much as it is in pre-renal causes. And this usually is due to renal atherosclerotic disease or malignant hypertension, which leads to damage to the blood vessels, which in the end will lead to a lower perfusion. So you might get as signs and symptoms for this persistent hypertension and peripheral edema. In terms of post-renal causes, you can either have kidney stones, as we've discussed, retroperitoneal fibrosis, and intra-abdominal tumors. So with kidney stones, if you have a stone blocking only one ureter, the renal function is usually preserved, but the patient might present with pain on their flank. But it wouldn't lead to AKI. Whereas if you happen to have stones in both ureters, this is when you get post-renal AKI. And yeah, you might get a renal colic, all complete anuria with stones blocking both ureters. Retroperitoneal fibrosis is just inflammation of the retroperitoneum, which can compress the ureter and thus causing post-renal AKI. And there's many causes for this. Idiopathic, so sort of unknown from trauma or particular medications. And intra-abdominal tumors, they can compress as well on your ureter, blocking the urine flow. In terms of things that can affect the bladder, we've mentioned benign prostatic hypertrophy, which is just a non-cancerous increase in the size of the prostate gland, so much more common in men over 50 years old. So we can see here how the prostate gland is compressing over the urethra, leading to slower voiding or eventually no voiding at all. And also prostate cancer can affect the urine outflow in the same way as benign prostatic hypertrophy. In terms of urethra, you can get stones in males particularly. You might have a urethral stricture or phimosis. So once again, with stones, since they're blocking the common path of urine, you will get anuria with this and pain in the urethra. With the urethral strictures, they can be caused due to trauma or catheterization or infection. So once again, urine won't be flowing. And phimosis is just when the foreskin of the penis cannot stretch to allow it to be pulled back. So once again, there's problems with the urine flow. And another thing, and another thing that can cause AKI are post-renal AKI are various medications such as anticholinergics, alpha-adrenergic agonists, or calcium channel blockers. And the way in which they cause AKI, catheter obstruction. It's not a drug, but I would like to highlight that you should keep in mind that before thinking of anything more complex, if you have a patient that already has a catheter in and there's no urine outflow, do check that it's not obstructed. But going back to the drugs, anticholinergics block the action of acetylcholine, so there will be fewer bladder contractions, so the patient won't feel the need to urinate, and this is how it can lead to post-renal AKI. So the bladder won't be emptying, and these can be sometimes given as antidepressants. Alpha-adrenergic agonists, they determine the contraction of the internal urethral sphincter. So once again, the bladder won't be able to empty. And calcium channel blockers, they inhibit, once again, bladder contraction. So the urine won't be passing from the bladder to the urethra. Signs and symptoms. I know this slide is a bit information heavy, but I thought it would be good as a summary related to the things we've covered up until now. So patients can be asymptomatic initially, then they can develop oliguria or absolute anuria, and this is particularly common with post-renal AKIs. Signs for volume depletion are the ones we've seen already, so hypotension, tachycardia, reduced skin turgor. If they're fluid overloaded, you might see edema, hypertension, shortness of breath. And when their toxins are building up, you will get uremia, which can cause nausea, encephalopathy, pericarditis, or even clotting problems due to platelet dysfunction. In post-renal AKI, you will obviously see a distended bladder if the blockage is below the level of the bladder, incomplete voiding, or pain over the bladder or flanks, pain over the flanks, especially if there's stones in the ureters. And general symptoms you'll get are fatigue, confusion, and lethargy from the toxins building up. And in very severe cases, you will get either seizures or a coma. In terms of investigations you can do, I've sort of split them up into urine, bloods, arterial blood gases, ultrasounds, ECGs, just to sort of categorize them a little bit. So urine investigations, you can do a dipstick, which might reveal proteinuria and hematuria, depending on the cause of AKI. So these might be present in nephrotic or nephritic syndromes. If you do microscopy, you might see red blood cells or red cell casts. For bloods, your hemoglobin levels might be low if they have been bleeding or due to increased hemoglobin, red blood cell breakdown from hemolysis, or you might have a raised white cell count, for example, in acute interstitial nephritis. Use and ease, you might have elevated creatinine because of poor excretion of it. Potassium might increase, and sodium can be either normal or low if they're volume overloaded. It's low. You could also do liver function tests if you're suspecting a liver cause, and you would expect to see albumin low, and it can be low either because the liver isn't producing enough of it or because it is being lost, such as in the case of glomerulonephritis. And bilirubin can be raised when the liver is failing. So in the hepatorenal syndrome we've seen. CRP can be elevated, suggesting infection or inflammation. If you suspect rhabdomyolysis, you'd also probably ask for a creatine kinase, which will be elevated due to the muscle breakdown. And you can ask for very specific specific tests if you suspect intra-renal causes. So these are all antibodies, so anti-mitochondrial antibodies, anti-nuclear antibodies, and anti-glomerular basement antibodies, and these are all related to glomerulonephritis syndromes. Your ABGs might show low levels of bicarbonate, which are suggestive for acidosis, which can be a complication of AKI, which obviously needs to be managed. If you ask for an ultrasound, it might show, you might assess the kidney size, and it might be big due to hydronephrosis. So that's usually because there's a renal obstruction, or you would get a hydroureter. Once again, the ureter will seem larger, distended because of the urine that's building up before the obstruction. And the ECG might show signs of hyperkalemia. Now, first question. There will be 5 questions, by the way. So an 81-year-old man presents to the emergency department after collapsing, and before losing consciousness, he was feeling lightheaded and had palpitations. He was unconscious for less than a minute and he had no chest pain. Cardiac examination didn't show any abnormalities. and you perform an ECG on the patient, which shows signs of hyperkalemia. So which of the following is a sign of hyperkalemia? And I'll open the polling system. 1 second. Okay, so just go for the poll and answer. I'll give you a couple of seconds. Okay. Yes, so well done. A lot of you chose tall tented T waves, so this is very important to keep in mind. When you suspect severe hyperkalemia, you would also ask for an ECG, and this will show tall tented T waves. Well done. All right, so correct. I've put this slide in order to figure out, in order to help you differentiate between pre-renal and intra-renal causes. So it can be helpful if you're looking at the urine osmolarity and urine sodium. So in pre-renal causes, the urine sodium levels will be very low in the urine. And this is because most patients are hypovolemic, and that will lead to increased retention of sodium in the hopes of retaining water as well. So it won't be excreted because the kidneys are functioning normally. And so there's low excretion of sodium in order to keep as much of the water in as possible. And the urine osmolarity will be high. Whereas in intrarenal causes, you will have increased levels of sodium, and this is because the kidney isn't functioning properly, so the sodium isn't being reabsorbed, and this will lead to high urine sodium as well as a low urine osmolarity, since you are eliminating a lot of water as well. So yeah, and just the definitions for these: urine specific gravity compares the density of urine to the density of water. So pre-renal, the density of urine will be higher than the density of water, basically. And this is because, as I was saying, you are trying to retain as much of the water as possible. And urine osmolarity is the number of dissolved particles per unit of water, in case you weren't sure about that. But sometimes these indications can be unreliable, because urine osmolarity and specific gravity can be affected by the levels of glucose in the urine, which you might get glucose in the urine if you have poorly controlled diabetes or high glucose levels in your blood, basically. So you shouldn't always assume that this will help you differentiate between pre-renal and intra-renal causes. All right, let's see question number 2. So once again, I'll activate the poll for it. 1 second. Okay, so I've activated the poll. So 60-year-old man presents to the intensive care unit, is admitted to the intensive care unit after abdominal aortic aneurysm repair. And he received 4 units of blood during the surgery. And during the first 24 hours, he only passed a small amount of urine. He has chronic heart failure, hypertension, and he takes multiple medications, atenolol, enalapril, and spironolactone. And he appears ill with a temperature of 37.1 degrees Celsius, heart rate 110 per minute, rest 18 per minute, and a low blood pressure of 110/78. Examinations shown dry mucous membranes and flat neck veins. The serum creatinine and blood urea nitrogen are elevated compared to before. So which the further investigations are most likely to reveal what? All right, let's see. I'll just give you a couple of moments to process this. Yeah, it's a lot to read. All right, think we're done. So yes, low urine sodium is the correct answer. And this is because what he has been having is basically a pre-renal AKI due to the decreased perfusion of the kidneys during the surgery. So he needed a lot of blood because he was losing it, and that led to AKI. And as we saw in pre-renal AKI, you tend to have low urine sodium levels. The history isn't suggestive for, say, any glomerulonephritis, so you wouldn't expect hematuria or proteinuria. You wouldn't necessarily expect for him to have acute interstitial nephritis either, which is the situation in which you would expect to have leukocyte casts. One second, yeah, perfect. My mouse wasn't working, sorry. Well done to all those that responded. Okay, now in terms of management, let's try and make it a bit more systematic because we've been covering quite a lot. So I like to think of the main goals of management, which is minimizing the degree of kidney insult, reducing complications, and if possible, restoring the renal function to pre-AKI levels, or restoring it as much as possible. And also, I like to keep in mind things that are important to correct, as they can lead to various complications. So you'd want to correct the hypovolemia, the hyperkalemia, if they have acidosis, and stop any nephrotoxic drugs, obviously, so that we don't exacerbate the AKI. And all throughout, no matter what you're doing, you want to monitor the patient. So take their OBS, check their fluid status, and urinary output. This is essential in seeing if they're improving or getting worse. And you'd also look at the U's and E's once again, check for the hyperkalemia and so on. Okay, so I think this slide will be quite helpful in terms of how we can tackle AKI in general, since there's so many things that can cause it. So if you have AKI, if the patient has AKI, you'd probably expect a high level of creatinine. So this might be suggestive for AKI, and it can help classify the stage in which you are in. Now, if you have low sodium levels in the urine, then this is suggestive for pre-renal AKI. And you should always start thinking of things in this way. You start by thinking about pre-renal causes, then you'll go to post-renal causes, and only after that you think of renal causes. So right now we are suspecting pre-renal AKI, and in this case we need to check the volume status. So they can either be volume overloaded, in which case you might consider giving diuretics, or volume depleted, in which case you would give volume replacement, so IV fluids. If the urine sodium isn't low to suggest pre-renal AKI, then you'd want to order an ultrasound, which might reveal hydronephrosis or hydroureter. So this might show that there is a post-renal cause of AKI. If there's a post-renal cause of AKI, obviously you will want to relieve the obstruction. So maybe either putting a catheter in or something like that. If you've eliminated this possibility as well, only then you start thinking of intra-renal causes. And for those, you would investigate either a few urine studies or even biopsy. And the reason this algorithm is in this way is because pre-renal and post-renal causes are quite easily managed and straightforward, whereas intra-renal causes, you'd most likely need the review of a nephrologist, and you'd want to do special studies for those in order to figure out the specific disease. And I'd also like to mention that you wouldn't necessarily do a biopsy unless that might help with management. So if you already have quite a good idea relating to the cause of the AKI, even if it's intrarenal, you just go and treat that and see if the patient improves, if there's a very high suspicion of a particular cause. If not, you would do a biopsy to narrow down the possibilities. I hope this is clear. All right, Let's do another question. Let me open the polling again. Question 3. Okay, so 65-year-old female presents to the A&E with shortness of breath after a 3-day history of vomiting and diarrhea. She has a background of chronic kidney disease. On examination, you notice dry mucous membrane, but otherwise normal, and the ABGs are below. What is the next best step in the management of this patient? Okay, I'm gonna wait a little bit for you to reply. Right now, the results are 50-50 between 2 answers. So let's see if they'll go towards the right answer now. All right. Okay. So let's see what you guys answered. So 50% opted for IV sodium chloride and 38% opted for IV sodium bicarbonate. And the correct answer is IV sodium chloride. And the reason for this is that she's definitely volume depleted. The IV sodium bicarbonate isn't an unreasonable thing to suggest given the low pH, but the thing is this pH isn't low enough for us to necessarily want to treat this acidosis right now. So the first step would be to deal with deal with her fluid status, and then if her pH say would keep decreasing, then we would worry about that. But right now it's not low enough for us to have to treat it. I hope this clarifies it. Now these are a couple more slides related to management, and I've sort of split them into pre-renal, renal, and post-renal causes, but they can sometimes overlap, of course. So as I've mentioned, you want to think about the volume status, the cardiac function, as it might be the thing that's causing the AKI, or even the possibility of sepsis, which is a common cause of AKI. Keep that in mind. So in terms of volume status, we've said they can either be hypovolemic or fluid overloaded. And if they are hypovolemic, you would want to give 50 milliliters of crystallate over 15 minutes. And then obviously always reassess. If they're still in shock, you'd give further boluses until they're either euvolemic or you've given them 2 liters of fluids, in which case you'd seek expert help. If they're fluid overloaded, you can think of giving them oxygen, because that can help with the pulmonary, with like oxygenating them in case they also have pulmonary edema. You might think of fluid restriction and diuretics. I've written here cardiac function, as it can be a main cause of pre-renal problems. So check if the heart is functioning all right. Or sepsis, in which case you think about the mnemonic sepsis 6. So you want to give oxygen, take blood cultures, give antibiotics only after you've taken the blood cultures. Fluid challenge, then measure their lactate and their urine output to see how they're doing. In terms of intra-renal causes, you do a renal screen and ask for a nephrology review. Renal screen is basically specific tests which can point out to a specific intra-renal cause of AKI. So yeah, as I've mentioned before, look at various antibodies that are specific to different glomerulonephritis. Or you would do a kidney biopsy, and depending on what you see there, it might help you figure out what the cause of AKI is. And obviously always ask for the help of a nephrologist. Like, all these are expert things. You wouldn't do them yourself. And the treatment for intrarenal causes is very much specific to what's producing the AKI. So for example, if you have tubular necrosis or contrast-induced AKI, you want to think about giving more fluids, or you might think of like giving extra fluids before performing a contrast investigation to decrease the likelihood of the patient getting AKI. And if you diagnose them with rapidly progressive glomerulonephritis, you might think of corticosteroid therapy in order to immunosuppress them. For post-renal, you might want to catheterize them. Always try that. If that isn't helping at all, you might need a ureteric stent if the blockage is in the ureters rather than in the urethra. Or you might even do a percutaneous nephrostomy, which simply means putting in a tube through the skin all the way to the kidney to allow for the flow of urine if there's an obstruction lower down. Okay, when to give dialysis? Does anybody know when we should give dialysis to a patient? Let me open the chat, sorry. Any ideas? Maybe this will help. Thinking about A, E, I, O, U. Okay, so A stands for acidosis. So if the pH is lower than 7.2, you'd worry. E, electrolyte disturbances. So if there's persistent hyperkalemia of more than 7 millimoles. E stands for intoxication, so from various drugs. O, edema. So if they have refractory pulmonary edema, so you're trying to treat them, but the edema isn't going away. And U stands for uremia. So if they have symptoms of uremia, such as encephalopathy or pericarditis. And this is an interesting fact. Even though the patient might need dialysis, there is a chance that they will recover to their original function, but some patients do develop chronic kidney disease after requiring dialysis. So 10% of the patients will get CKD. All right, and let's see question number 4. Let me start the poll again. Okay, so she has oliguria and hematuria, and she was diagnosed with AKI. What's the indication for okay, so the results are quite split between two of the answers. Let's see. I'll give you a couple more seconds for it. All right, so chest pain relief by sitting forward is the right answer. Only 43% of people got it. And the reason this is correct is because this basically symbolizes pericarditis. So high levels of uremia, which are causing pericarditis, which is definitely an indication of dialysis. Many people answered that the blood potassium of 5.5, 5.8 is an indication for dialysis. It's not high enough for that. It should be over 70 millimoles per liter in order to be an indication for dialysis. All right. So this is just a summary of things we've covered in terms of complications. So pulmonary edema from the fluid overload, acidosis from loss of reabsorption of bicarbonate, uremia, hyperkalemia, hyperphosphatemia, and hypocalcemia can happen as well. So all these are due to impaired renal excretion. And the final question, which is quite long, let me launch the poll. So 71-year-old hospitalized, develops abnormal lab studies after 4 days after starting treatment for congestive heart failure. He has a history of osteoarthritis, BPH, and he recently completed a course of amikacin for bacterial prostatitis. His medications before were simvastatin and ibuprofen, has a low blood pressure, and his creatinine and blood urea nitrogen are of 2.3 and 48 respectively. So, and urine osmolarity is 600, where sodium is only 10 milliequivalents per liter. So what's the most likely explanation for this patient? Renal insufficiency. Okay. I'll give you a couple more moments to think. All right, and I'll end the poll here. So the correct answer is volume depletion. And this is basically very much suggestive due to his low blood pressure. And he has started treatment for congestive heart failure. So he's probably taking too many diuretics. And this has led to the volume depletion, which has contributed to the AKI. All right. In terms of takeaway messages, there's many more than only these, but just know that AKI is staged either on the serum creatinine or on the urine output. It can be divided into 3 main groups. We've mentioned them: pre-renal, renal, and post-renal. And treatment is very much defined by the cause of your AKI, which needs to be identified. Acute tubular necrosis is different than acute interstitial nephritis. So keep that in mind. They're very much easy to confuse. So ATN is because of nephrotoxicity or ischemia, whereas AIN is basically an allergic reaction to various medications. And when you're thinking about a patient in terms of the management algorithm, you want to exclude first pre-renal causes and post-renal causes, because this is sort of easy to do. And if those aren't the things that are causing the AKI, then you want to investigate potential renal causes of AKI. So I hope all this makes sense. And I'll have a look at the questions that you might have asked in the Q&A. Okay, so somebody says that they thought that ACE inhibitors are used to treat kidney disease. And this is sort of true in the sense that ACE inhibitors are given in chronic kidney disease, but they should never be given in acute kidney injury. And the reason for that is in acute kidney injury, you don't to increase the gradient between the afferent and the efferent arteriole, because this will lead to a further decrease in glomerular filtration rate, which wouldn't be beneficial. But in chronic kidney disease, ACE inhibitors are actually renoprotective because they decrease the level of proteinuria by decreasing this pressure gradient. So I hope this clarifies it. Okay. So doesn't ACE inhibitors affect aldosterone and ADH instead of the afferent arterial vasoconstriction? So yeah, they are related to aldosterone, but like the end idea is that they lead to the constriction of the afferent arterial. Sorry, they lead to the vasodilation of the efferent arterial. And let me look at the chat, 1 second. Oh, and I haven't mentioned this, like if you can do fill in the feedback form. So I don't think there are any other questions. So thank you very much for coming up for this lecture. I hope it was somewhat useful. And yeah, please, if you have time, do complete this feedback form. It won't take too long. But yeah, it was nice presenting. Bye.